Okay, I guess we'll go ahead and get started. I'm really excited to introduce our next speaker, who is pre-recorded her presentation because she's at the ACP, so she couldn't be here doing it live for us on Zoom. So this is Dr. Darilyn Moyer. She's the Executive Vice President and Chief Executive Officer of the American College of Physicians, the ACP. She attended medical school at Temple University School of Medicine and completed her internal medicine residency at Temple University Hospital. She was a chief resident and clinical instructor of medicine there. She went on to complete her infectious diseases fellowship at Harbor UCLA Medical Center in Torrance, California. Prior to becoming the ACP's executive vice president and CEO, Dr. Moyer was a professor of medicine and executive vice chair for the education in the Department of Medicine, the internal medicine program residency director, and an assistant dean for graduate medical education at Lewis Katz School of Medicine at Temple University. And she's won multiple awards, including the American Medical Women's Association Elizabeth Blackwell Award, as well as the recipient of the 2020 Lewis Katz School of Medicine at Temple University Alumni Achievement Award. So without further ado, I'm going to play the video. It seemed like it worked, so hopefully it'll work when I push play.
The EVP and CEO of American College of Physicians. I am so grateful that you invited me to be part of this fantastic conference, and I appreciate your allowing me to pre-record this since I haven't received my cloning machine yet. And as you see me here, I am actually at the ACP Internal Medicine Scientific Meeting in San Diego for the week. So I'm going to go ahead and share my screen, and let's see if this works. Think it's working. You think I'd have gotten this right after 3 years of the pandemic. The title of my talk today is, and then there were four, Gender Equity and National Professional Society Leadership. I have no intellectual property or other disclosures. I will give you my imposter phenomenon introduction, which is that I'm a PGY38 internal medicine and infectious diseases physician who currently practices part-time. I'm a recovering internal medicine residency program director, assistant dean, ACP governor and regent. I'm in my 6th year as the EVP CEO for ACP. Now, I show you this, this tongue-in-cheek shout out from the NewYorker.com addressed to Rosalind Franklin. Thanks so much for your hard work on unlocking the secret to the helical structure of DNA. Great stuff. It's been very useful for us. So sorry to leave your name off the paper. We totally forgot. We're such scatterbrains. By the way, could you fill out the online catering order for our Nobel Prize celebration luncheon? Awesome sauce. We may be Nobel winners, but we're just so bad with technology. And, this is truly how it feels for women in healthcare. I still get called nurse, and I very graciously but firmly correct people to remind them that I introduced myself as the attending physician, the supervising physician, and ask the patient what they need from the nurse. And this cartoon, of course, says we're doing everything we can to make him comfortable, short of dressing up as male doctors. If I had a nickel for every time I had to correct someone, I've had a big pile of nickels in my career. And I think for the message here and the reason why we need to get men engaged and the folks in the power structures engaged is that getting to a just, equitable, diverse, and inclusive environment in healthcare is not a zero-sum game. We all get more. And that if you're not speaking up about it, silence is equivalent to complicity. And as Dr. Yeoman said, allyship can no longer be an option, but an imperative. And this is borrowed from Dr. Julie Silver, who so brilliantly talks about the structural and systemic issues that are pervasive in our society and healthcare that result in women standing in this line, women who we don't expect to fix this issue, but we really need to assist with an assist from a top-down approach as well as a grassroots approach. We might do this, which was transiently switching the men's room to the ladies' room, as we did at the Marriott in Brooklyn a few years ago with an AMWA meeting. Dr. Del Rio, now the interim dean at Emory, has said shattering the glass ceiling is an urgent priority, and we can't expect women to do it by themselves. And we know that for facts about women in business leadership, whether it's healthcare or not, when women lead, performance improves. But it's very challenging for women because of the power structures and the systemic inequities. To break down barriers that hold women back, it's not enough to spread awareness. If we don't reinforce that people need and want to overcome their biases, we end up silently condoning the status quo. And we certainly know that there is a lot of data around gender equity being good for human outcomes, for organizational outcomes, and for financial outcomes. And what we know is that women and historically marginalized groups in medicine are recruited, evaluated, advanced, promoted, mentored, sponsored, and compensated differently than those in the majority power holding groups. And this is through the entire career of women in healthcare. The data around women conference introductions, speaking times, interruptions, appropriation of comments and contributions is also very concerning. And despite the fact that the National Academy requires that AAMC affiliated hospitals and healthcare organizations maintain a clearly written Bill of Rights and responsibilities, communicating a zero tolerance policy for sexual harassment towards healthcare workers, when 55 of these policies were polled, none of them contained the recommended language. And of course, we see the increasing attacks and prevalence, as well as sexual harassment of physicians, and particularly women, in social media. The intersection is crowded. There's a lot of Venn diagram overlap, but there are a lot of important distinguishing features amongst women versus other historically marginalized groups. So I'm going to talk a little bit about ACP's journey here. In order to understand where we're going, we need to understand where we came from. So by the end of the 19th century, the number of women physicians grew to almost 9,000, but they were excluded from membership in medical organizations, so they formed their own. In fact, American Medical Women's Association was formed in the same year, 1915, as ACP was. But unfortunately, by 1937, there were only 57 women physician members in ACP. And here's a glance at what the 1982 Board of Governors looked like. And the Board of Governors is our ACP's house. And it's a pathway to national, international leadership. And you can see here that these are predominantly white men. But we're making headway here. And if we take a look at gender identity for our full Board of Governors, we went from basically zero in 1982 to about a third of our Board of Governors is now with women who, people who identify as women. Now, Adam Grant's has written a lot, been very prolific, and he's at Wharton, which is a neighbor to me since I live in the Philly area. And what he did with his MBA students was he presented data to talk about the lack of women in leadership roles at Wharton, and was talking about the factors that held women back. But despite that discussion, there was no change in the percentage of female MBA students who applied for leadership positions. So the next year he tried something else. He added one simple sentence, asking people to do something about diversity in leadership. And he saw that just at adding that, empowering people and telling people that he believed in them, increased the application for women for leadership at Wharton by about 68%. So where are the women and the non-white folks? This is the Freedom Caucus, ironically discussing women's health in 2017 up on the Hill. Well, we're standing in those bathroom lines waiting to be elevated. So ACP has a history of a lot of women first. We, had our first women elected to fellowship around 1920, but then there was a huge gap. And you can see this timeline here. It was in 1989, actually the year that my first child was born, that the first woman was elected to chair the Board of Governors. In 1996, our first female president. In 2003, our first female chair of the Board of Regents, which is essentially our Board of Trustees. And the first time that an award was named for a woman was 2007 with the Jane DeForge Distinguished Teaching Award. We're so proud of the fact that we got a phenomenal editor-in-chief with Dr. Christine Lane, who joined the Annals of Internal Medicine in 2009 as editor-in-chief. Virginia Hood as our first international medical grad woman president, and I'm the first woman CEO. Now, my origin story is that I grew up poor in rural Pennsylvania on my pop-pop's farm. My parents were big believers in education and love to sustain you. They were both survivors of the Depression. They were both around 5 or 6 years old at the time the Depression hit. And although my mother had to quit school at the age of 15 to help to support her younger siblings, she was one of 8 siblings in a poor Polish family. My dad did graduate high school, but I was the first person to actually get to college in my immediate family, let alone a medical school. And like many of us who chose careers in healthcare, we were influenced by someone. And for me, it was an unusual person in 1960s and 70s rural Pennsylvania. Dr. Sandra Rowan was my pediatrician, and she empowered me to think about a career as a physician. And from there on, I had my marching orders, and I decided that I wanted to do this. I wanted to make a difference in people's health. Now, there is an important partnership of institutions, medical societies, and academic journals to have a pivotal step in ensuring systematic change that addresses gender inequity, which is what Dr. Eliza Chin, a very close friend and colleague, said. So we started this journey, actually, ironically, the month that I became the CEO. The Council of Resident and fellow members for the ACP brought a resolution to the Board of Governors, which was approved unanimously. It went to the Board of Regents. It was approved unanimously to expand the policy around gender equity for our organization. And we talked about several things: physician compensation, family and medical leave, leadership development, unconscious bias training, research on gender inequity, and opposition to harassment, discrimination, and retaliation. And then we married that with our commitment to becoming an actively anti-racist organization. And we know that if we don't implement policy, it will sit on shelves and grow dust. And so it was important that ACP walk the talk. So we have created a lot of resources, and we have really undergone a very extensive data-driven path to achieve justice, equity, inclusion, diversity, and accessibility within the ACP that I'm going to talk about a little bit. We created this as a strategic priority, but it now really is part of the fiber and the DNA of the organization. We look at everything we do with a lens of health equity for our patients, health equity for our organization, equity for our staff as well. And we follow really Dr. Silver's systematic approach. Medicine is a data-driven science, and we have to take a look at what does the data show us. Talking about the data, investigating causes of disparities and implementing strategies to correct them, tracking our outcomes, adjusting our strategies as needed, and most importantly, talking about what we found. And metrics for all leaders really needs to include the important realization that board representation is key. Boards of organizations should reflect the people on the front lines of those organizations. And in healthcare, it should also reflect the people that we're caring for. So board representation is really important. And Dr. Farzana Hussain, who's a gastroenterologist at Penn, wrote a phenomenal article in the Philadelphia Business Journal in 2017. She actually took a look at the healthcare group organizations in Philadelphia. And even though 80% of the healthcare professionals were women, less than 20% of the healthcare institution CEOs were women, and less than 25% of hospital and health system board members were women. Leaky pipelines and sluggish middles. And I'm happy to say that ACP has made dramatic progress in this regard. Our Board of Regents is 2/3 women. It's almost half people of color. We need to do better in terms of international medical graduates, and we're working really hard with our grassroots and our board of governors here. About a third of our board members are under the age of 52. We have marked geographic and practice diversity. Now, we all know the tale of the lack of progress, or I should say, the glacial progress that we have seen in academic advancement, where less than 20% of chairs and deans are women at academic health centers in the United States. But the other concerning trend is occupational gender segregation. Dr. Amy Gottlieb, Dr. Molly Carnes have written and spoken about this, that even though more and more women are entering medicine, and now well over half of medical students are women, trainees are continuing to distribute into specialties that in ways that reinforce rather than mitigate pre-existing gender imbalances. Women are going into more women-friendly or perceived women-friendly domains: pediatrics, OBGYN, psychiatry, internal medicine, family medicine, PM&R. They're not going into the more procedurally oriented specialties. So we think it's really important that we have these hard discussions and figure out how we can get to a better place for this. And for ACP, this has meant communication, coordination, collaboration with our partners in this space. Our DEI focus is really around three initiatives. It's around initiatives internally in our organization with our staff. It's in initiatives around ACP's leadership pathways with our grassroots at our board of governors and chapter leaders, all through our national, international, and then of course the work we do in terms of our patient realms. And our goal, and as a professional society, is to measurably improve lives and reduce the inequities in health and healthcare by dismantling inequitable practices, including promoting inclusion and diversity, embedding racial and social justice into professional society infrastructure, equipping healthcare professionals to advance racial and social justice via education, and addressing social and structural drivers of health. So we've done a ton of work both internally and externally in terms of policy and advocacy. We've forged a lot of external collaborations. We've established a bunch of affinity groups within ACP. We've revised national and mastership descriptions to remove biased language, and we've done deliberate efforts to peek around corners and seeing who is getting missed. And of course, we're tracking and reviewing our data, making adjustments, etc. And so this is an illustration of the work that we've done over the past decade or so in terms of ACP's national awards and masterships. And that is that we saw very few women, and this is not something you self-nominate for. Masterships and awards are nominated by others, but we were seeing very few women and people of color getting nominated for MACP and awards. And so we really started to make deliberate practice reaching out to folks in the grassroots of our chapters and saying, who are we missing that are incredibly qualified for MACP and awards? And I got to tell you, it was sweat equity, truly doing this. And we saw, as you can see here, dramatic increases in the number of women that have been nominated for awards and masterships. We have a lot of work to do, though, with international medical graduates and people of color as well. But we continue to do this work. We think it's important because, we need to get the best people, and they are out there. And when people say to me, oh my goodness, you have so many women on your board, I say, that's really interesting that you say that. Boards were predominantly men and predominantly white men for many, many years, and no one ever commented on that. So these are the best qualified people as well, and I think we need to continue to message that. And as I said, Dr. Christine Lane, who was the best qualified for the position above and beyond all the other candidates, is also leading the way with the work that she is doing internally with her editors, deputy editors, associate editors, as well as her editorial board and the publication committee for Annals of Internal Medicine. And we see that there are still marked disparities in the publication arena. And Dr. Lane, Diane Scott Lichter, ACP's Chief Publishing Officer, are doing a lot of work within the journal world to make sure that we are publishing the most important pieces, and to be making sure that we are looking for those publications. Now, you may have asked why the title. Well, the title is "And Then There Were Four." When I became the CEO of ACP back in 2016, there was only one other woman physician who was a CEO of a major physician professional society in the United States. And now there are four. This is the CMSS, the Council of Medical Specialty Societies. I was on their board in 2022. I was the president in 2021. But Dr. Maureen Phipps, who's the OBGYN CEO, Dr. Patricia Turner, the ACS CEO, along with Dr. Helen Burston, the actual CEO of CMSS, means that we now have four women physician CEOs out of about 50 national, international physician professional societies. So that's exciting. It's glacial progress, but we're getting there. The wonderful thing is that we all support each other, and we're very gender blind. New CEOs that come on, we help to support them as well. And so I think it's been a really important message to see the incredible diversity that the CMSS board, which basically represents over 800,000 practicing physicians in the United States, has. And I'm happy to say that Dr. Helen Burston is also an MACP, and Dr. Vinnie Aurora is also a member of NAM. Now, we've seen a lot of our progress be dissipated by what happened during COVID. And I refer you to this first it was presented at the WIMS Summit and then published in the Journal of Hospital Medicine, Dr. Vinnie Aurora's work around how we need to change the rubric for academic advancement. We know that women and people of color are burdened with a lot of additional service that doesn't count towards academic advancement. They do a lot of advocacy work. So we really need to uproot these classic and very old and staid methods of academic progress and advancement, and really begin to contemporize them through the lens of what is critical to your organization's mission, vision, and goals. Now, if people don't want to do this because it's the right thing to do, I can tell you that one compelling way to get their attention and to get them moving on this is that AAMC, ACGME, the Joint Commission, and other credentialing and certification organizations care about health equity. They know that high quality, safe environments in healthcare are those that are free of discrimination and harassment. And that gets people's attention when you start to talk about this. So getting to a just, equitable, diverse, inclusive, and accessible healthcare environment is going to require important foundational work that is going to be reviewing the policies and procedures of your organization in everything you do, and making sure you implement appropriate anti-harassment and discrimination policies that are accessible, and that people don't feel that they're going to be punished or marginalized for accessing. You got to make sure you have an oversight body with teeth in your organization to get this done. When I talk to people about looking at positions, I tell them they've got to differentiate between responsibility and authority. If you are given huge responsibility to accomplish things without appropriate authority and empowerment within the organizational structure, you are doomed to fail. We got to understand how we allocate our important resources to achieve this. We've got to have deliberate practices in data collection. We've got to talk about it. We've got to educate folks about why this is important. And you've got to review all of the standards that your organization is held to. At the end, she is someone's sister, mother, daughter, wife. And let's help to amplify each other. This was the New York cartoon that says, "That's an excellent suggestion, Miss Triggs. Perhaps one of the men would like to make it." We've all got to support each other. And I'm talking to the men in the room and the others that are potentially the power brokers at organizations as well. There's always light if we're only brave enough to see it, if we're brave enough to be it. This was inspirational recently at the shared with me by Dr. Susan Hingle of a young medical student who shared a Medical Women's Association, I would say, montage around women in medicine. And with that, I just want to thank you for your time today. I want to thank you for all the work that you do on the front lines of care and all the work that you do in getting us to a better place in terms of gender equity, inclusion, and accessibility. Thank you.
Great. All right. Thank you all for taking the time to listen through the recording. Dr. Moyer is really inspirational. She's done a lot of really amazing work. Hopefully we'll get her to come to our institution sometime in person so that you'll have an opportunity to meet her and talk with her at that time.